That's LCL. Move upwards. Then move backwards. Good, good. Good. Find the fibula head now. Otherwise, we are the popliteal fibula ligament. Okay, you can try, but I think this is capable to do the fibula ligament and also the popliteal fibula ligament. They are all written in our slides. And one more for the yesterday's class. I'm quite interested about the arcuate ligament. We are looking at the arcuate ligament, but we don't know where it is because of the device. Okay. So because no arcuate, this is not the position for arcuate ligament. This is, but we don't know where it is because it's not very clear. But if this is the artery, this is the arcuate ligament. We identify the arcuate ligament. Identify the artery first. Okay, thank you. We are going to start our lectures. So we are going to give you 5 minutes to start the lecture. Thank you very much. Yes. We finish the lecture about 4:30. And I will remind you to go home 4:45. We will pack and leave here before 5 o'clock because you stayed too long yesterday. It's a punishment. Sorry, it's a joke. So, because today is Friday and the traffic outside, as I know, is very, very bad. So we don't want to stay here for too long and delay the time for families. Families always come first. Families always come first. Okay. And if my colleague work with me, they are very unhappy with their job and they are exhausted and they look like pissed off and they do not smile in office. I will tell them, share time with families. Family is always the best power for people. Okay. And I know some of you work with the sports team, so we are going to spend some time to talk about the low leg and maybe ankle a bit. Maybe ankle a bit. I planned it to look at the foot, but today probably not the case. Some of you may notice I open Mahito very often, and I stay there for a long time, very long time. Last year, the first time I stayed at Mahito, I stayed for 2 months. Yes, and I visit Mahito very, very often. So we were discussing about some lectures for ultrasound, probably this year. If you are interested for more classes, please contact them or contact Adam Preacher. But the problem, one question we need to sort out is, you want more anatomy or more precise, more detail about the shoulder and knee and ankle. If you want more detailed structures, we need to prepare a better devices. If you want to practice the elbow, wrist, or the foot, I think Chinnason will be helpful. Okay. Today will be no easy at all for everyone. I think the Mahito staff, they agree with me. When the first time they think the shoulder is very hard, very difficult. When I teach them the knee, they think the shoulder is difficult. They think the knee is very difficult. And when they learn the leg, they know it's very, very difficult. So like hard, very hard, and very, very hard season in Thailand, yes. So today will be very, very difficult. So please be focused. But I try to simplify everything I know. So this is the most important figures you need to remember. Okay, it's 12 structures, like our clock. Do you have any difficulty to remember 1 o'clock, 2 o'clock, 3 o'clock? No, right? Because when you look at the clock very often. So let me tell you, 12 o'clock, tibial and dialis. 1 o'clock, extensor digitorum. 3 o'clock, 2 o'clock. Sorry, there is another one. Okay, 12 o'clock, tibial and dialis. 1 o'clock, extensor hallucis longus. 2 o'clock, extensor digitorum longus. 3 o'clock, peroneal longus. 4 o'clock, brevis. Easy, right? Easy. You have a leg, right? You have a clock watch, right? Look at, so from today, 12 o'clock means tibia and dialis. Everyone follow me, right? Okay? 3 o'clock, peroneal longus. 4 o'clock, brevis, because anatomy, according to the anatomy, the brevis is a little behind. But brevis is very naughty. Why? When the brevis close to the medialis, the brevis took the places of longus. Just like when you drive in Bangkok, right? You are waiting for turning. Someone just over you and without giving any warning, right? That's brevis, very naughty. Yeah, but longus is not a weak muscles. The longus took brevis places again after past the medialis. So medialis is like a turning, the street, right? When you turning to the another directions. Okay. Ooh, where is the book? Oh, it's all right. Okay. When you are turning, when you are driving and you are turning, right? The longus is here. The brevis is here. Basically, brevis should wait for longus to turn, right? But during the turning, the brevis take the shortcut. And the longus has to go outside and turn. But when the brevis close to the insertions, the longus do the same thing to the brevis, took his place. Okay, so 1 o'clock, 2 o'clock, extensor hallucis longus. Sorry, 12 o'clock, 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock, brevis. Then, remember, gastrocnemius and soleus. Okay, then 4, 5, 6, 7, 8. 8 is the flexor hallucis longus. 9 is the flexor digitorum longus. 10, tibia posterior. Okay, if possible, you can add Pontaris in this area. Make it totally 12 structures for you. Okay, the 11 o'clock is the neuromuscular bundle. of the tarsal tunnel. Then you back to the tibia. So you move from the front of the tibia, laterally, 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock, 11 o'clock, neuromuscular bundles. That's it. If you cannot remember the detail about the number, just look at the watch. The more you can remember, the more easy for you to learn ultrasound about the lower leg and ankle. We are not going to discuss anything about the foot today. Okay, because you know the directions, so you have the opportunity to understand the muscle injuries in the lower leg. The lower leg, it was reported. If you work with a team with the football player, 25 players will have 15 muscle injury per season. But most of these 30% injury lead to 30% of absence in the season. So a lot of injuries keep the injured athletes away from competitions. The prevalence is very low in calf, but mostly the calf muscle causes the most serious injury. So basically, a lot of football players, they have hamstring injury, adductor injury, and they have a lot. But these muscles injuries in the hamstring or adductors do not usually keep them away from the competition, but the calf muscle injury do keep the athletes away from the injury. Right? This is a review for you to remember your clock. Okay? Pontaris. Neuromuscular bundles. Right. Because we are going to look at the muscle in the leg. So we need to communicate with people who are interested or who are also looking at the injuries. This is an easy way to communicate with our colleague or medical doctors. If we are talking about the mild, the moderate, and the severe, it's basically by the functions. But if we are talking about the finding from the imaging, we will talk with the change in the cross-sectional area. For example, a golf player has, when he worked down from the hill, and the green hill, he a kind of sleep had a sleeping movement, and he feel it's okay, but something wrong in the leg. And you use ultrasound to check, oh, it's minor tear. The minor tear, the size is less than 5% of the cross-sectional area, or 5% loss of the function. It's okay. It's okay. And this kind of pain usually do not stop people to do functional activity, but they feel the pain increased when they are doing the sports. And our job is to use tapping or warping to reduce the gap of the injury and also protect the people away from recurrent injury or the enlargement of the gap. If you look at the injury is the the muscle injury was found with a very obvious hypoechoic area, and they are swelling. So, and the stretching induce the pain. So you probably can talk to your colleague. This is a larger tear, and because this kind of finding may lead to 5% to 50% of functional loss. So you can use the tear size in the cross-sectional area to predict the loss of function. If they are massive or very big area, show the hypoechoic hematoma or swelling, you can predict it's a complete tear, and the function, the loss of function will over 50%. Let's look at the following examples. Oh, sorry. This is an example of muscle injury in the rectus femoris muscles. The border is hypoechoic because usually the muscle looks like this, right? Did you use your ultrasound to look at the neuromuscular bundle, and you found the head of the medial gastrocnemius and the lateral gastrocnemius is very, very clear, right? Like sunglasses, right? Right? It's okay. If you didn't, we will practice later. Okay, don't worry. So during the practice, you need to know what the cross-sectional area looks like, what the longitudinal area looks like. And we are going to use tibia and tibialis as an example, a more difficult muscle than gastrocnemius. Gastrocnemius is easy. Okay. Did you remember I demonstrate the vastus latialis yesterday? I said this is a skill of focus, right? Vastus latialis is a typical example of unipennation. Unipennation is a very, very good target muscle for research. Okay. If we are looking for a muscle like tibia and tibialis, it's bipennation. Bipennation means basically at least there are two layers. The two layers do not work as one. They do not work as one. Just like soleus and the gastrocnemius, they work separately. Okay, so we often use ultrasound to look at the pennation angle, like tibia and tibialis, and to observe the gliding over the superficial layer and the gliding of deep layer. And we want to know which layer get injury, both or just one. I know there are some motorcycling accidents in time. It's very common in Taiwan as well. So when a case with motorcycling injury, and they tell me they get hit, on the lower leg, we often use ultrasound to check the range of the injury. It's a superficial layer only or deep layer as well. Okay, superficial, we can use modality treatment for the superficial part. If the deep layer is involved, I would suggest, I personally would suggest electrotherapy for deep muscle stimulations. Okay. Okay, so low-grade muscle may difficult to find because the hypo area may be very small, okay, and the pennation probably not become invisible. So if you are you would like to find the tiny muscle tear, you want to reduce the dynamic range. 2, increase the dynamic range. 3, you don't know what is dynamic range. 4, you don't know what I'm asking. Okay, tiny mean tiny hypo, tiny duck, right? Tiny duck. But you say, I'm going to reduce dynamic range because you are looking for something dark, yes. But you will be very disappointed because reduce the dynamic range, lose the detail. Okay, so in that case, the only resolution is find a high resolution probe. Okay, if you are looking at a tiny or small injury, do not try find a better probe first. If you don't, and you cannot have one, then try to use the dynamic range. But sometimes may not be functional. Okay. If you find the pennation and the physical and the pennation disappear in some hypoechoic area, it is an indication of the muscle injury. But remember, when you are going to do this kind of assumptions, muscle, fat, superficial aponeurosis, physical, pennation angle, deep aponeurosis, bone, everything in your imaging has to be clear. And you found a hypoechoic region with discontinued physical, then you suspect this is maybe the location of muscle injury. I might agree with you. But without clear skin, fat, superaponeurosis, physical, pennation angle, deep aponeurosis, fat, the fat between muscle and the bone, without these clear borders and the lines, you can't do anything. Okay, so you have, in order to have this imaging, you need to know how to use the skill proper. 7 skill, right? 7 skill. So ultrasound need a lot of practice. The biggest area before is ultrasound is very expensive. No one can buy it like a toy and bring ultrasound with you every day and you can use every day. No, but ultrasound is going to be cheaper and cheaper because the crystal inside is going to be replaced by semiconductor. Semiconductor is very cheap. And the semiconductor technology in Taiwan is good. It's good. Some people say very good, but it's good. So a lot of ultrasound company, they are going to move to Taiwan because Taiwan company help them to use the semiconductors, as the resources for the sound wave, not crystal. Crystal is very expensive. But semiconductors, the life of a semiconductor is slightly shorter, and they decay slightly quicker. So the semiconductor ultrasound is very good for wireless probe. You do not use very frequently, but you use for occasion. So they are very cheap. So if someone tell you, I got a very good wireless ultrasound, but the prices does not come cheap, no, nonsense. Because you can ask them, is the sound wave is provided by crystal or semiconductors? Yeah. Sorry. I think most wireless. I think most wireless made in China is semiconductor. I believe, but I believe, yeah, because the prices are very low, right? Okay, good. High-grade injury always show the fibers are disorganized and flat. So basically, there is an angle, pennation angle. If the pennation angle get flat or show no tensions, that means the muscle fiber is ruptured, and there are some fluid and a hematoma. In this case, the compression is the best way to deal with. And you can use your 6 scale compression to test the hematoma is solid or not. If it is solid, you can start some exercise. Because the scar, the hematoma eventually becomes scar. The scar had its strength as well. Okay. Like I said yesterday, good. This is the bone. If there is a stress fractures, and you found thickening, periosteum. Okay. This is the fracture, tiny fractures. And you found that the periosteum is become thickening. And you found a callus here. C-A-L-L-U-S, callus. You can start weight bearing. Without the callus, okay, immobilize. The callus, basically, the callus could be observed 2 weeks earlier than X-ray. So, if your medical doctors or the doctors refer patient to you, say, okay, don't do anything after 6 weeks, because they got the knowledge from the X-ray. Okay? If you look at the colors, and in the very beginning, the colors is full of blood. Okay? And you recorded 1. And a week after, you recorded, and you found that the blood is decreased. Means the colors is becoming natural. Started weight bearing. Not full weight bearing, but partial weight bearing is okay. If your medical doctor has some opinion with that, you can show him the imaging. So now, with the ultrasound help, we probably start the weight bearing, partial weight bearing exercise 1 to 2 weeks earlier than before. Okay. The year of 2000, I worked at NTU hospital. The tibia fractures, at NTU, immobilized 6 to 7 weeks, at least. Some doctor would like to 10. Some doctors. Now is 4 to 6 weeks. And some people start the partial weight-bearing exercise after 4 weeks. And a lot of colleagues in other countries, especially in Japan, they think you are crazy. That's risky. I said, yes, but we check through the colors. Or if the gap did not appear, right, at all, we will tell the medical doctor, okay, this patient have risks of non-union. Do something now. Okay, the same, it's good. Yes. Yeah, power. Yeah. Color will do as well, but if you want to have a higher sensitivity, use power. Yeah, use power. If the gap, if the colors is not observed for 3 to 4 weeks, then you should check the literature whether or not this kind of fracture is very common with non-union complications. Yeah, so that's why the scaphoid. We often check scaphoid. Yeah. A friend of mine, he loves any kinds of car. He has a building for his cars. Yeah, and he ran to a competition for the 4x4. Okay, and there is a rock, and he drive on the rock, and the handle just turned sharply, and he got a hit on the scaphoid. And he went to our hospital. We checked by the ultrasound, no gap. And my colleague, medical doctor, told me, ask him, does he need a pin in the scaphoid? And now we have a discussion about if they put a pin inside, the RM of the MP joint will decrease. Very obvious, as well as the wrist. And he does not want to do that because he likes to drive a race car. So he wears a custom-made brace. Yeah, and now he has 2 scaphoid now. But everything is okay. But sometimes painful. But he does not want to have a surgery because he knows that already. We tell him what's going on if you don't do this. But if you don't do this, you have other options, like we can give you custom-made. So we use 3D printer to print a custom-made brace for him to drive the race car. Yes. Yeah, scaphoid. Yeah. And I read the article. Yeah, it is reported. The people who drive the 4x4, if they do the rock and they drive too fast, the handle sometimes turns sharply and quickly, and hit the scaphoid. Yeah. Okay. I like to teach ultrasound because the room is dark, cold, and easy to get sleep, right? It's okay. Go to sleep. Don't get cold. Yeah, but I was a student. So I will make you, I was a student before, so I will make you stand up and practice when you are tired. Yeah, don't worry. Go sleep. Yeah, have some rest. That's the hypocoid. This is a transverse view of muscle. Okay? This is the standard view of muscle transverse. You can see the deep aponeurosis over the fascicle. Within the muscle is very bright. Okay? This is standard. No hypoechoic in this area is normal. Especially the hypoechoic area with discontinued fascicle. Okay? The fiber here, still okay. The fiber around this area is swelling or ruptured. So you can use the area percentage to predict the functional loss. And this is grade 1. This is grade 1 injury. Okay. If there is a rupture, you ask the patient to do some muscle contractions. You may see the gap appear in the rupture site. Okay? And this is another example. We cannot see the detail of the muscle. The detail of muscle almost gone. Right? Okay, look at this one. Then, look at this one. Healthy. Injury. Obvious, right? It's very dark. It's very dark. So, some sonographer, they told this is starry line, a dark sky with a lot of star. So you know the life of sonographer is very boring. Yeah. This is starry line. Okay. Without the star, swelling, there are some injuries. Okay. Now, we begin to practice, because I think half of you are already a little bit tired. We are going to start from 12 o'clock, tibia and dialis. Then, look at the muscle at 3 levels. Upper third, middle third, lower third. In the upper third, there is no extensor hallucis longus. Just a little bit head of the extensor hallucis longus. In the middle third, you can observe tibia anterior flexor hallucis longus and extensor digital longus, then fibula head. So you may find now, okay, everything is continued in anatomy. Yes. So the level 2 lectures is not look at this level. No. The level 2 level will be moving the probe around upwards, downwards, lateralwards, medialwards, and to see anything connected to each other and close to each other. Right? And you have to know what you are looking for and make the preset change necessary, if necessary. Okay, so we are going to look at the tibia anterior, okay? And the Mahito stuff will remind you there are 2 layers. And your job is scan the muscle and find the bipennations. Yes. Is it easy to get the rubber band on floor in time? No. Rubber band. You know what I mean, right? Okay. So it's not easy to get rubber band. Anyone has a rubber band? No, not Sarah band. Yeah. It's very easy to find the rubber band on the floor in Taiwan. But for me, it's okay. In Edinburgh, everywhere is chewing gum. Ooh, chewing gum in Edinburgh. Yeah. Okay. Cool. So we need to have a small leg. Okay, now. Okay, thank you very much. And we need to trace the tibia anterior down to the end. We need to find the extensor hallucis longus. This example, I think, is too long. We can find the extensor digitorum longus in here. Yeah. This sample, these figures is the location for the extensor hallucis longus is too long. Hallucis longus is about here. Start from about here. Yeah, okay. Then we look at the extensor digitorum longus. Extensor digitorum longus is very easy to identify because here is the location of fibula. If you look at the fibula and then you move forward, this is extensor digitorum longus. Okay, we move everything from the top to the bottom and to the end and look at the tendon. Okay, so I'm going to use this table to do the demonstration, and the Mahito staff will help you to practice. Okay, any questions? No? Good. I know you are confused. You will be more confused 10 minutes after. I guarantee you. So, preset. To focus. Persistence. We want to reduce the noise. So we have to move very slowly. If we increase the persistence, yes. When you increase the persistence and you move the probe during the examination, move the probe very slowly. Okay. Smooth. We don't age enhancement. Yeah, maybe we need it. Okay, acoustic power. No. Good. Dynamic range. We are looking for muscle and tendons. So why not increase? Eye imaging, compound. Okay. The compound functions, basically the sound wave is transmit in this way. Okay. The compound function means sometimes the sound wave transmits in this way. Sometimes it transmits in this way. So for better age of structures. Okay. But with proper skill of heel walking, you don't need compound functions. But it's okay. Depends on you. Okay. Okay, good. Ready?
Ready.
Sure?
Sure.
Okay, good. All right. So this is the medial side. Professor. Okay. Yeah. So I'm looking for the side, right? So with the sticker, no problem at all. Yeah, yeah. You want to show name? Yeah, can you give me one, please? The black, yeah, I prefer black, yeah. Thank you very much. Thank you. Okay, so make a smart guy like this one, so I can handle it. And I know this is proximal, or this toward to tibia. Okay, so the best way about Barry machine is you return it, so you don't need to worry too much. Okay. Okay, this is a muscle here. Okay, tibialis anterior. Can you give me the pointer? Thank you very much. Thank you. Tibia anterior, a border. Small. This is the deep peroneal nerve. Yeah, deep. Yeah. Okay. So the deep peroneal nerve stay with tibia bone. Yeah. Until it go to the foot, the front ankle. Okay. So yeah, tibia anterior. Okay. Oops. TBR is 12 o'clock. Go, 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 go. Pimongkong, are you okay? So which one you are going to see, this one or another one? You here? You are? Really? Okay. Okay, go, 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 go. We are looking for a central. This is interosseous membrane. This is tibia posterior. That's why we said this is tibia anterior, this is tibia posterior, because they face to each other with an interosseous membrane. This is tibia posterior, okay? I think someone already noticed the bright layer, the superficial layer is bright, the deep layer is dark, right? There are two layers, okay? Don't worry, I will contact my colleague this afternoon. When we close, when we close to the a border between the superficial layer and the deep layer. Okay, so you check the pination angle structure here, not above. Above this level, you cannot find the pination by pination structures. Okay, use the skill you learn. And use the rotation skill. By pination. What did I do? Okay. So the distal side is okay. The proximal side is not clear. So I have to move. The central upper neurosis in the proximal side is not clear. So the physical here, this is the central, the border between the superficial and the deep layer. This is the angle in here, this is the angle in here, right? Okay, the rubber band. Is this okay? Never mind. You, I said, if you cannot hear what I said, right? The echo here. The echo. Oh, you help me. Yeah, the shadow produced by the rubber band can be seen in the window, center of the window, right? There's a dark line, right? It's created by rubber band. Okay. It's very clear, right? Oh, we find things. Because okay, there's a triangle. This is the end. Tibia anterior. Okay, and the ano in the under the yes, very much. You read my mind. Okay. Hold it, yeah. And start from neutral position. That is lengthening, yes. Because the tibia anterior was stretched, so the moves is slightly different. Okay, this is good. Okay, dorsiflexion. Move backwards. Go, 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 go. Go, more. Relax. Okay, slowly. Let's do it again. Okay, slowly. Dorsiflexion. Move back. Yeah. Go. More. Okay, relax. Slowly. Too fast. Now, let's do it again. Go. Slowly relax. Good. Back. Good. More. Relax. Okay. Do you see the movement? Move distally, proximally. Okay. And the rubber band can help you to make sure your probe is moved or not. Right. Otherwise, don't do anything, okay? I can cheat you like this. Go. Oh, relax. Go. Relax. That's bullshit, right? Okay. So sometimes study cheat. Yeah, I think. Yeah. Okay. With the shadow in the middle, I know my hands was not moving. Okay? Try this when you practice. Okay, start again. Hey, very useful. I always know where it is. Good. Tibia anterior, go. And can you extend your big toes a little bit? Yeah, it's here. The head. Yes, thank you. The head, thank you. Sorry. The head of the extensor hallucis longus here. A little bit. This is the extensor digitoris longus. Okay? Okay, good. Extensor anterior tibialis. Go. Two layers, right? Yeah, thank you very much, Pimon. Thank you, Professor Pimon. Professor Pimon is done very quick. Very quick. Yeah. So student from Chulalongkorn, there is another one, right? Yeah. Okay. So hold her foot for me again. There. Okay. Dorsiflexions. Good. Okay. The edge, thank you. The edge of tibialis still stay here. If the edge of the tibialis move away from the tibia anterioris herniation. Yeah. Let's do it again. Dorsiflexion. Go. Yeah, still, stay with tibia. If the muscle ending leave or away from the tibialis anterior, that's the muscle herniations. Actually, I think the screen is more clear than right. The monitor is clear because you can see the margins in here. Right, the TV does not show. There's a margin here. The border of tibialis. Okay, let's go. So again, start from the beginning. You need to find the two-layer structure, turn 90 degrees. Find the penetration and ask her. Okay, hold her foot. Dorsiflexion, slowly. Go. Come on, do something. Yeah, thank you very much. Relax. Yeah, okay, relax. Good. Yeah, thank you. And turn 90 degrees. Okay, go. Pass the rubber band. Go. And then, this is extensor hallucis longus. And then, you find the border of the fibula, the border between the peroneal and the extensor digitorum longus. The border, that's peroneal, extensor digitorum longus. Okay, so the best way is to do interlaterally. Okay, but you have to look at the tibia, extensor hallucis, and also extensor digitorum longus. So you have to turn the legs if necessary. Okay, I think because we have a lot of people here today, so we just practice the tibia and the alis. Okay, turn 90 degrees. Practice, turn 90 degrees. Then, okay, tibia and the alis, go. Then our beloved tibia and dialis tendon is coming. Okay, good. See? Two little kids become one. This is not so bad, really. It's still very good in my hands. Two little kids become one. Ladies, gentlemen, tibialis anterior tendons. Okay. Then, when you close to the anterior ankle, the tibialis anterior will cross over the tibia bone. Does not like extensor hallucis longus. Extensor hallucis longus stay with, go to the big toe. Okay, good. Dun, 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 dun. Dun, 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 dun. Cross tibia. Dun, 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 dun. Dun, 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 dun. Dun, 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 dun. Look at my hand. my hand is not in front of tibia anymore. I'm turning to the medial side, right? Because for you, I need to put the tibia and ears in the middle of the window. Dun, 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 dun. Okay. I think we are very close to the insertion. Right. Exercise 1. Exercise, sorry. 1, 2, 3. Dun, 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 dun. Okay, extend your big toe. Good. Say hello to extensor hallucis longus. Dun, 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 dun. Dun, 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 dun. Tendon. Dun, 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 dun. Right? So it's very interesting, right? Extensor tendon of tibialis anterior, extensor hallucis longus. If you cannot find the tibialis anterior, or you cannot find the extensor hallucis longus, they stay together like a high school boyfriend and girlfriend, but they separate eventually. Oh, sorry, for some cases, yeah. Right. Okay. Dun 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 dun. Tibia. Oh, how are you, my high school sweetheart? Extensor hallucis longus. Right. Sorry, I have to go with extensor digitorum longus because he is my love now. That's the extensor digitorum longus tendon. If you do not know him, let me introduce him very well. This is tendon of extensor digitorum longus. Okay, right. So, I don't know. The love story with 3 people is always very attractive, right? So you can make a story for tibialis anterior, extensor hallucis longus, and extensor digitorum longus. Good, tibialis anterior. I stay with tibia because tibia is my mother. See, I always stay with my mother because my mother family is very important. Tendon came out, right? Good. But extensor hallucis longus, extend your bit. Yes, very tiny, because we were kids together, right? But when we grow up, I grow stronger. You still stay with your mother. I have to go. But life is very strange. Extensor hallucis longus. Why we meet together again? Tibialis anterior. Flexor, extensor hallucis longus. Right? Extensor, tibia idealis, extensor hallucis longus. I hope this kind of rubbish story will help you to remember their relationship. and tibialis anterior, flexor, extensor hallucis longus, right? Okay, my new boyfriend, he is very young, so the size is very small. I mean the tendon size. The tendon size is very small. Good, and very superficial. Because the extensor digitorum longus tendons have a lot of branch, so the size is very small, right? Tibialis anterior, tough. Flexor hallucis longus, tough. Yeah. Okay. So you need to trace, observe the 3 muscle, 3 tendon. Okay. Dun, 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 dun. No, no, yeah, it's because of jelly. No, it's all right. This helps a lot. So I don't need to look at my probe frequently. Dun, tibialis anterior. Dun, 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 dun. Good. The border between the flexor, extensor hallucis longus and the tibialis anterior appear. Yeah, it's a kidney shape. Kidney shape. Dun, 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 dun. And this is extensor digitoris longus. Okay. Dun, 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 dun. I know you are confused. Good, I told you. You can leave right now before it's too late. Okay, just make fun on you. If you get lost, they are high school friends, right? Basically, actually, the flexor extensor hallucis longus, like the tibia posterior in front of his door, her door, right? So this 4 people in one love story. Well, very complicated. Right, so if you cannot find the extensor hallucis longus, increase your depth, find the interosseous membrane. Tibia posterior just in front of her. Okay, easy, right? It looks like you have this kind of story before, so you can remember everything I said. Good. Dun, 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 dun. Interosseous membrane, good. In front of, okay. Extend your big toes, slide it. Yeah, good. Okay, relax. Good. Yeah, easy. If you cannot find the high school boyfriend, look at your interosseous membranes. Good. Go. Tendon. Go. That's the tendon for extensor hallucis longus. All right, this is the tendon. Okay, good. Go. So extensor the tendon of the tibialis anterior already crossed the tibia, right? Extensor hallucis longus still stay in front of tibia. Go. So, when we look at the tibialis anterior tendon, this is the tendon of the, we found the tendon of the tibia anterior. Put it in the middle of the window, 90 degrees. This is the tendon. Very close to the cortex bone of the tibia. Very close to. Then you follow it all the way to the insertion. Okay? All the way. All the way to the insertion. This is the tendon, right? There's tendon fiber inside. I think you know there is Amazon coffee downstairs, right? Okay. If you if you have big problems in this, I think everyone deserves a coffee. Cool. Go. Okay. Don't worry. Tibia and anterior tendons. Okay. Extensor hallucis longus tendons. Right, they were high school friends before. TA, extensor hallucis longus. Oh, good, good, good. Go, 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 go. Okay. Pimon, can you help me? In the middle, yeah, under. Yeah, because the no, because the range of my cervical is not good enough to turn over 90 degrees. Yeah, I think I've become a yeah, thank you, thank you. Higher. Yes, this one. Okay. Then we turn 90 degrees. Then we turn 90 degrees. Okay, this is the tendon of extensor hallucis longus. Good. Then with muscle fibers. Okay. Thank you. If you are looking at the tendon of tibia and tibialis, tendon, bone. Look at the extensor hallucis longus, tendons, muscle fibers. Because, as I said, the extensor hallucis longus muscle bed is lower. So, in the lower leg area, you still can see the muscle fiber. Okay. 3 exercise. 1, 2, find the 2 layer. Turn, contraction. 3, to the end. 4, back to the origin. Find the extensor hallucis longus. Okay, then go to the end, turn 90 degrees. Do it. Otherwise, you can go to the Amazon coffee.